Hey everyone, welcome back to Poem Peeps and to another Rapid Fire Journal Club episode. I'm here with Luke Hedrick and Robert Wharton, who hosted our last Rapid Fire Journal Club. And Luke is our associate editor, so we're in charge of our whole initiative to review modern literature. I am only joining for this episode because it's about pulmonary arterial hypertension, about a new treatment that's out, something I'm really passionate about. And so this is one I just couldn't afford to miss. But Luke, I will hand the reins over to you as the boss in this situation.
Thanks, Dave. And I think you're here more than just because of your passion. I think your expertise here is going to be very helpful while we take a look at this trial. Um, and Robert, thanks again for bringing this to us. So why don't we go ahead and get into it? Robert, what paper are we talking about today?
Yeah, so we're going to talk about the Stellar trial today, which is a study of Sotatercept for the treatment of pulmonary arterial hypertension. I've been on a big ICU Ed and Todd bender lately, and so I've been thinking a lot about grading the trial names. You guys tell me how you feel, but for me, it's more about the how cool is the word than does it match up with exactly what the acronym is supposed to be. So I give this an 8 out of 10. Cool word. A lot of the other trials in the same space have other space-themed trial names, which I really like, but what do you guys think?
Oh, I love it. I think it's always nice when the family of trial names are all sound the same. I feel like it helps me remember stuff. So the Pulsar and Stellar and Hyperion and all this stuff is I love it.
Yeah, I think it's spot on, A plus. And we'll have to get you when Ed and Todd come back on Poem Peeps for a collaboration. We'll have to bring you in as well, so you can have a conversation with them about their grading process.
Awesome.
All right. So before we dive into the paper itself, Robert, help us understand what's the background info here that we need to know to talk about the paper. Help us put this trial in context.
Yeah, so before this trial, the available therapies for pulmonary arterial hypertension work to relax smooth muscle in the pulmonary vasculature and to decrease pulmonary vascular resistance. And these include things like endothelin antagonists, phosphodiesterase inhibitors, the guanylate cyclase activator riosigwat, and some compounds targeting the prostacyclin pathway. These things have all been shown to improve hemodynamics and exercise capacity. They were approved on the basis of their improvement in the 6-minute walk test, but have made pretty disappointing progress towards improving survival in patients with PH. So there's been a real need to find disease-modifying therapies. So meanwhile, our basic scientist colleagues had identified that the most common heritable mutation occurring in the PH patients was in the bone morphogenetic protein receptor 2, BMPR2 gene. And without getting too much into the alphabet soup here, there's a whole family of TGF beta ligands that work at this receptor and play an important role in pulmonary vascular remodeling through regulation of proliferation and differentiation. Sotatercept was a drug that was actually developed for the treatment of myelodysplastic syndromes and works at this receptor, but it's been repurposed for pulmonary hypertension. What it actually is, it's a fusion protein. It has the Fc domain of the human IgG linked to the extracellular domain of the human activin receptor 2A. And what it does is it acts as a ligand trap. So it soaks up some of these selected pro-proliferative TGF beta superfamily members and rebalances the pulmonary vascular homeostasis towards inhibiting growth and pro-apoptotic signaling. So in summary, this might be the Anakin Skywalker of pulmonary hypertension. Maybe it'll bring balance to the force. So we'll talk about it.
I like that. So it sounds like we've got a pretty promising new drug that works through a novel mechanism. And so Dave, I can see why you were so excited to talk about this. This is a really exciting space.
Yeah, it really is. And as Robert pointed out, we have a lot of drugs for this. We do have good evidence that if we use those drugs smartly and effectively, and we improve patients' risk scores quickly, that they can have mortality benefit over time. But it's always been in this combination therapy. It's always been a little bit reactive. We're really doing vasodilation, and we're always searching for this key of remodeling and getting people better with a long-term ongoing prognosis. This is a really great translational medicine approach of looking at a family of patients that have this gene, then honing in on the gene, honing in on the pathway, and then redeveloping to deploy at the bedside. So we've been excited about it for a long time, and yeah, it's finally at the forefront and now clinically available.
All right. So that is all really helpful context. And maybe it's time to get into the paper itself. Robert, why don't you tell us a little bit about the methods? What did they actually do?
Stellar was a multi-center, placebo-controlled, double-blinded, industry-sponsored, randomized controlled trial conducted over 24 weeks. And participants received a subcutaneous injection of either Sotatercept or placebo every 21 days. And their primary endpoint was changed from baseline at week 24 in the 6-minute walk test.
Yeah, and the 6-minute walk test, I think maybe we can hit pause and turn to Dave here for some commentary. I think it's a criticism that you could make of a trial like this is that's not necessarily the most patient-oriented outcome. And so, Dave, I was hoping you could talk to us about that particular outcome and how it fits into the PH literature more broadly.
Yeah, that's a great point. So 6-minute walk's an interesting one for PH, actually for most of our pulmonary diseases. We use it in ILD, we use it in COPD. I think the beauty of it, or the reason people like it for a trial like this, is that it's very reliable, easy to reproduce. You just have to have a patient who can walk in a hallway and you time it, and people who can do it with the patient. It has been a metric that is pretty easy to show. You don't need huge numbers to show improvement, as opposed to, say, mortality or worsening of disease with hospitalizations, where your power calculation would necessitate that you have absolutely enormous numbers to show a difference. So you can predict a difference in 6-minute walk with more statistical power. That being said, it's not clinically meaningful in and of itself. So we often look at the secondary outcomes too. But with 6-minute walk, the most important thing that we have to keep in mind is what is the clinically meaningful difference? Because you could end up having a statistically meaningful difference of 10 meters, but clinically, we know that probably doesn't have an impact on mortality. We do know that for patients with pulmonary hypertension, that if their 6-minute walk is increasing, decreases their risk score, decreases their risk of mortality within the coming year. And for each disease, you really have to think about the minimal clinically important difference. And there are papers all about these. The most quoted one now for pulmonary hypertension is actually pretty recent, sort of saying, hey, this is happening for a lot of trials. Are we okay with this outcome? It was in the Bloom Journal in 2023 by Muccia et al. And like a big group of very respected pulmonary hypertension researchers. And they ended up saying that a difference of about 33 meters is the one that we think is like the most important clinically meaningful difference. So we just keep that in mind with outcome. But I will say, when I read these papers, I also want to look at hemodynamics. I want to look at proBNP, and I want to look at more clinically meaningful outcomes like mortality.
Yeah, that makes a lot of sense when you frame it that way. And while it's not the same thing as quality of life and it's not the same thing as hospitalizations or mortality, I think if you can have an intervention or a drug that takes a patient's world from being 70-meter radius of whether their chair or their bed is and makes it 100, 130 meters, that probably is meaningful for that person, even if it's not a hard number like a PVR or an admission or mortality.
And I'll actually also just add one thing, is that the hemodynamics can sometimes be a little misleading, right? Because we know a lot of these drugs will lower hemodynamics, and that doesn't always mean improvement. So like a big example of this is in the COPD population that gets secondary pH. We can treat them with pH drugs. We can actually improve some of their hemodynamics, and then sometimes actually their mortality ends up being worse. So the hemodynamics are really important. We follow them a lot, but they don't always tell the full story of how the patient's being impacted.
Right. Okay. And so we've talked a little bit about how interpreting this, we'll want to look at those secondary endpoints too. Robert, can you tell us about them for this paper? Because there were a bunch of them and they handled them in kind of an interesting way.
Yeah, what this trial did was something called hierarchical secondary endpoint testing, which means that they would start with one secondary endpoint and then only proceed to the next hypothesis test if the first hypothesis test was significant. So they had 9 secondary endpoints. The first one was a multi-component improvement measured by the percentage of patients meeting all 3 of improvement in 6-minute walk by greater than 30 meters, improvement in NT-proBNP level, and improvement in WHO functional class. And then they had separately the components of that, as well as change from baseline in pulmonary vascular resistance and a time to first occurrence of death or non-fatal clinical worsening, defined as a large number of things, including heart and lung transplantation, rescue therapy, atrial septostomy, hospitalization. And then worsening of pulmonary arterial hypertension defined by worsened WHO class and worsened 6-minute walk test, and some risk scores like the French risk score. And they had a health-related quality of life questionnaire called PAH SYMPACT that had been previously validated in this population. What's really cool about hierarchical testing is it reduces the false positive rate. Because you can imagine if you do 20 hypothesis tests at once and you have an alpha of 0.05, you're guaranteed to find one positive test. So this controls for that error rate. It's more conservative. And the only other statistical point I'll mention is that analysis was by intention to treat.
All right. So now that we know what they did, Robert, can you tell us who they actually enrolled? Who were the patients in the trial?
Yeah, so these patients had group 1 pulmonary hypertension or pulmonary arterial hypertension with some exclusions for portopulmonary disease, schistosomiasis, HIV, pulmonary veno-occlusive disease. And they had been on 1, 2, or 3 other therapies for PAH or background therapy for at least 90 days prior to enrollment, and they needed to have a PVR of at least 5 Woods units. Importantly, they only enrolled patients with a functional class of 2 or 3. This is equivalent to the New York Heart Association functional class, where class 2 is dyspnea with normal activities, and class 3 is dyspnea with less than normal activities. Class 4 would be dyspnea at rest. And importantly, they excluded these class 4 functional class patients. They stratified the analysis by the functional class and the number of therapies. And then in terms of who actually got enrolled, they're table 1. Most of the patients in the study were female, and the average age was in the late 40s. The vast majority of them were white. About half of them had idiopathic disease. And the majority, 60%, were getting triple therapy. 40% were on a prostacyclin infusion, such as treprostinil or epiprostinil. And we can talk a little bit more about their hemodynamic parameters. I think the headline is that the PVR was pretty high. It was greater than 9 Woods units, but the cardiac output and cardiac index seemed not to be as well affected.
Yeah, and I agree. Thanks for that description. Dave, maybe I imagine there's some nuances here to the population they enrolled and how that would reflect your panel and how we should interpret some of the results we're getting ready to talk about. Are there any kind of additional points you would want to tease out here?
Yeah, I think this is a great population to look at. It's a patient population with significant PAH. So even though they said PVR 5 Wood units, most of the patients were closer to 9, like you said, and that was on background therapy, and a lot of them on triple therapy, a lot of them on parenteral therapy. The cardiac output and index reflects the big point of including functional class 2 and 3 patients. And the fact that they had to be on stable background therapy is that these patients were actually responding pretty well to their background therapy. This is not for the new diagnosis. This is not for the person who's still functional class 4 or cardiac output is still in the toilet because they have decompensated RV failure. So just you're thinking about outpatients that have pulmonary arterial hypertension, have severe disease, but are on therapy and as of right now tolerating that.
Awesome. Thank you for that nuance and for kind of summarizing that for us. That's a nice way to frame who the patients in this trial actually were. And so, Robert, what did they find?
Yeah, this was a positive trial. The primary endpoint of 6-minute walk test favored Sotatercept by about 40 meters. And further, the first 8 of 9 secondary outcomes were also positive, which to me is more impressive than the 6-minute walk even. Some highlights from this were that there was a double the rate of week 24 WHO functional improvement. There was a very low hazard ratio of 0.16. That's an 84% relative reduction for the time to first occurrence of clinical worsening. And there was better symptom scores in the people who got Sotatercept. And the sicker patients seem to have a greater benefit in the trial.
Yeah, that is quite the positive results, just like you said. You mentioned sicker patients maybe having a little more benefit. Dave, are there subpopulations or any kind of nuances to that kind of overview of the results you would point out for us?
Yes, I do think that the big takeaway is exactly what Robert said. Very positive. Everyone was really happy to see this. Everything was going in the right direction in what we would anticipate. And I think a lot of us are really excited to get our patients on this therapy. The couple nuances or things to take away. One is just what we were already talking about is the inclusion of these patients. It's still unclear if this drug, which could be so promising, should be used in patients who are functional class 1, patients who are functional class 4, patients who are in acute RV failure or an initial diagnosis. So the timing of actually initiating it remains unclear, except for the actual population that was included in the trial. The other thing that's important to think about is just the breakdown of patients that were included in terms of etiology. This is really idiopathic and familial pulmonary arterial hypertension. And that's what we want to treat. That's the population that we worry about poor prognosis, often diagnosed at a young age. But another huge group is patients with connective tissue disorder. And that group, while represented in this trial, was a lower proportion. There's only about 20% of the patients. And so we do have to think about them a little bit differently. Do they have different responses overall? And could they potentially have different side effects that the broader idiopathic or familial population wouldn't have?
Yeah, and I'm glad you brought up the idea of side effects and kind of the safety of some of this treatment, Dave, because I know a lot of these pulmonary hypertension meds can have some pretty significant side effect burdens. And so, Robert, maybe you can walk us through the safety or adverse effects that they saw in the trial.
Yeah, in general, I would say that Sotatercept was well tolerated. There was actually less discontinuation for adverse effects in the trial group than in the placebo group. On the other hand, we did see more bleeding events, thrombocytopenia, telangiectasias, diarrhea, epistaxis, and dizziness, and increased hemoglobin in the Sotatercept group.
Yeah, and that's a good point too, that there were less discontinuation in the intervention arm than the placebo. That's always reassuring to see. It does put my ears up that the side effects that they did see are things that we may worry about seeing more of, just like you mentioned, Dave, in that connective tissue disorder population. So there may be more to come here, but it seems like overall, this was a pretty well tolerated med.
And especially when you compare with some of the known side effects of our existing medications, like a treprostinil infusion. I've seen some patients in the hospital in so much horrible pain because of that infusion, or with horrible headache or jaw pain or flushing. So I'm guardedly excited that sotatercept, with the caveat for connective tissue disease, could represent a better option.
Yeah. And it's nice that it's an injection that is not continuous, right? That they could do at home or initially probably in a clinic and then at home. But yeah, Luke, you hit the nail on the head a little bit with some of the telangiectasias, bleeding events. We're going to watch this. I know they're watching it. There were some reports of bleeding afterwards with the drug, but not enough to negate the findings of the trial. And then an important thing with the safety is also just things that you have to monitor for. So it does lead to this increase in hemoglobin. If that increases too much, then we actually have to dose reduce the drug or even discontinue it. So that's just a monitoring parameter. So you want to make sure that you're getting labs for your patients with the first few doses.
Yeah, and so I guess this is all of a theme of an exciting new drug, but that means there's a lot more information to come as we learn more about how to most safely and optimally use it for people. So, Robert, are there any limitations to the study that we should be aware of?
Yeah, this was a positive trial. In general, in positive trials, try to look for sources of chance and bias towards a positive finding. I have to say, I really can't find anything that could be a source of bias. Sometimes we look for selection bias by comparing the number who were screened versus actually randomized, and the proportion was quite high. It was about 3/4. So I have no concerns there. The intervention group and the placebo group were balanced at baseline. And I think the big smoking gun here is that 8 out of the first 9 secondary endpoints were positive. It would be very hard to believe that we had a false positive here. I think some of the future work has to do with where else can we use this drug. So one question is, how is it going to work in the long term? This is only a 24-week trial. And there's an open label extension of the trial called Soteria that's aiming to answer this question. And 2, what is going to happen with harder endpoints like mortality? And then talking about other possible indications, we looked at this in the setting of stable background therapy. So Dave, you alerted to earlier, what would happen if we use it earlier in the treatment paradigm, or if we use it in patients who are sliding, or in patients who are WHO functional class 4? And these are all open questions, most of which I think are being answered in ongoing clinical trials. Another thing that I think is important to bring up here is that minorities were not well represented in the trial. I feel like we have a duty to include minorities in clinical trials for a number of reasons. It could inform differential exposures and stressors that feed into health disparities, which might change how we implement pH care for those who need it the most. That said, I don't think it would do these patients justice to throw the baby out with the bathwater, as I sometimes hear done in journal clubs and say, oh, these are not the patients that I treat, so I'm not going to use the results of this trial. I think that would be wrong. Race is a social rather than biological consult and construct. And there's no a priori reason that I'm aware of that minority respond differently to sotatercept. Is that fair to say? Do you guys have any other thoughts on that?
No, I think you're totally right. I mean, this is a problem in medicine in general, is that it's hard to get recruited into a trial. It's hard to stay into a trial, and we do a bad job of this. But there's nothing to indicate that this wouldn't be helpful in some populations based on that alone, based on self-identified race or ethnicity alone. And we should definitely be making sure it gets into the hands of patients who are underserved for sure.
Agreed.
Yeah, Robert, I totally agree. Thank you for bringing that up to us too. It's always an important thing to keep in mind. And you mentioned too, this idea that thinking about different populations of patients and just thinking about the results here, there was a decent chunk of people who with sotatercept didn't improve their BNP and functional class. And so it makes you wonder about whether there's further work to be done about figuring out why those folks didn't respond. Maybe they have some different level of activity of these proteins that sotatercept is targeting. And then potentially the other way, is there potentially a future where we can test for some of those markers and try to predict someone who would respond well?
Precision medicine is always the right answer.
Yeah, I agree. I agree.
Yeah.
Yeah, and it'll be interesting for the other pH populations. So trust me, the drug company is trying this drug in group 2 and group 3 and group 4 and group 5, right? Because they want it to apply to more, especially group 2, which is our most common cause of pulmonary hypertension. But maybe it'll be a subpopulation of those groups that have remodeling that comes from a certain pathway that we're actually targeting here.
And they're also looking at targeting other pathways too, by the way. There's a trial in process looking at imatinib, which is a tyrosine kinase inhibitor. So really expanding this question of whether we can decrease the amount of proliferation associated with pulmonary hypertension and modify the course of disease.
And I'm just going to add one thing from the actual practical side of this. So I'm starting to prescribe this drug now. Really, our group is thinking hard about when to do it. We have a patient right now with a new group 1 diagnosis, and how are we approaching it and timing it? And one thing that's important, and what we had been waiting for and is now recently out, is what the FDA was going to think. Right? So the FDA approved this drug, and they have the access to the full literature and full data that they've reviewed with a fine-tooth comb. And I think that their approval reflects their belief in this trial. Without going into the full details of it, the biggest thing is the indication. They could have approved this for just group 1 on stable background therapy with certain limitations. They approved it for all people with group 1 PAH diagnosed who are functional class 2 or 3. No other questions about the timing of disease, about their clinical status when it starts, about if they're on stable background therapy. That's a very wide group of patients. And I think that must come from the people who are sitting on that board saying, look, this data looks pretty good. And so it'll be interesting to see how groups around the country start deploying it and how our patients respond.
Yeah, it's always interesting to see how things translate to real life out in the wild, outside of the safe confines of a trial. All right, so we've talked for a little bit about the paper, Robert, and then maybe Dave. Why don't you guys share, after all is said and done, what are your takeaways here?
I would just take away that this was a floridly positive trial, demonstrating improvements in 6-minute walk test, time to clinical worsening, hemodynamic parameters, and health-related quality of life in patients already on stable background therapy for pulmonary hypertension. And I hope that it represents a paradigm shift in the field towards disease-modifying agents that can help people live longer and feel better.
Yeah, I think Robert summed it up well, and I am excited for the new pathways that it opens for us and to see how the patients do on it. I think we've had a lot of progress with the existing pathways and drugs we've had, but then we're doing a lot of tinkering on the edges, new methods of delivery, new combinations, when are we starting them all? This is shifting entirely to a new pathway and a new group that we're targeting. Fingers crossed, and the time will tell how it plays out for everyone.
All right, and that is everything we have for you guys today. Thanks for listening to another one of these rapid fire journal clubs. Thanks again to Dave for the expertise and Robert for bringing the paper to us and walking us through it so well. We'll have another episode for you guys soon. Give us a review and subscribe wherever you get your podcasts. It helps people find the show.
We'll have to label this one not so rapid fire journal club, but I think it was worth the time.